Good evening, everybody, and welcome to yet another international webinar from IAGES. This is the fifth in a row, and I would like to welcome everybody on board today. And I would like to start by introducing our panelists today. First one, my dear friend David Lomento from Singapore. He is a professor and director of Minimally Invasive Surgical Center, also director at Khu Tech Puat Advanced Surgery Training Center, Yonglu Lin School of Medicine, National University of Singapore. He is also attained knighthood on 26th of December 2009. He was conferred the prestigious award of Ordine della Stella della Solidarietà Italiana by Italian government for his leadership in clinical service, research, and academic recognition as an expert in the field of surgery, minimal invasive surgery, and robotic surgery. I hope I pronunciated it right, David.
You speak Italian very well, Deep.
Thank
You
you.
are
Thank
very
you.
future. I
Thank
suggest
you
you go to the Italian embassy. It's very nice in Delhi, beautiful restaurant.
Thank you. Then we have Dr. Vinay Mahendel, who is from Mumbai. He is a medico-surgical clinic and hospital Mumbai, consultant in various hospitals in Mumbai, including SL Raheja, Fortis Hospital, Dhanvantri Hospital, HL Doshi Hindu Sabha Hospital, and many other. He is practicing surgery since 1976, and he is an ex-professor of surgery from Seth VC Gandhi, M.A. Vora Municipal General Hospital, Rajwadi, Tamil Nadu Medical College at D.Y. Patil Medical College, and he's also practicing laparoscopic surgery from 1991. Then I have a very close friend again, Dr. Muhammad Farooq Afzal. He's from Pakistan. He has a fellowship in advanced laparoscopic and bariatric surgery from the United States of America. Currently, he is a professor and head of surgery department of PGMI AMC Lahore General Hospital. He holds various positions in various society in Pakistan, including the Senior Vice President of Surgical Oncology Society of Pakistan, General Secretary, Pakistan Society of Metabolic and Bariatric Surgery, and various others. And he is practicing advanced laparoscopic upper GI and GI oncology surgery frequently. Welcome, Dr. Mohammed. Then I have somebody.
Welcome and good evening, everyone.
Then I have Dr. Praveen Bhatia, who all of us know very well and we admire him. He is one of the pioneers in minimal invasive surgery in this part of the world. Very, very positive, enthusiastic surgeon. He's a senior consultant, laparoscopic, bariatric, and robotic surgeon at Institute of Minimal Access Surgery, Metabolic and Bariatric Surgery at Sir Gangaram Hospital, New Delhi. He's also holding various positions in various councils and associations. He also is a managing director and owner of a global hospital and endosurgery institute in New Delhi. Welcome, Dr. Praveen Bhatia.
Thank you very much. Thank you.
Then we have two very enthusiastic, dynamic moderators today. M. Kanganavel, who is a very enthusiastic laparoscopic and GI surgeon. He is in Chennai. He has a keen interest in academics, research, teaching, and training. Then I have Dr. Sumit Shah, another friend of mine, who is a very eminent laparoscopic general surgeon practicing in Max Hospital, New Delhi. He is again somebody who is very well read, very enthusiastic, and very, very keenly interested in teaching training. Welcome, both of you. Then I have Dr. Raman Goyal, who is currently the president of Indian Association of Gastroendosurgeon. He's a senior minimal invasive bariatric and metabolic surgeon in Mumbai. We all know him very well, but he is very, very enthusiastic, and his enthusiasm and his smile is so infectious that I can't tell you. And we, in this year, even in these difficult times, the way he's leading our association is commendable. Dr. Raman Goyal, welcome, sir. And I would request you to say a few words of encouragement. Thank you very much.
Thanks, Deep. Good evening, friends. Welcome to this international webinar, what we call as International Academic Collaborative on behalf of IAGES. As COVID has affected lives of our patients, our practice, hospitals, but it has also opened up new avenues. We had no clue that after March, somebody who had no idea about Zoom would start doing hesitantly Zoom meetings for the physicians on COVID, and which we gradually increased to have more academic meetings for surgeons. And now here we are, a weekly international collaborative meeting where we have experts from all over the world, from our neighborhood, and also local experts. Then we have master classes on basic subjects every Sunday evening, 3-hour video master class, which in itself is attended by over 2,500 surgeons every week or every fortnight, depends on how we are able to organize it. And besides this, we are into many other things. We had first virtual executive committee meeting. We had virtual election, the new editorial board of JMAS taking over. We have started the YouTube channel. We are starting our app. We are starting IAGES Prime Time, which will be a weekly video related discussion. And you can name it, Twitter, whatever. So last 4 to 5 months has made a complete difference in how we approach education. And we are also starting online FIAGS, FALS and EFIAGS programs in endoscopy and advanced surgeries as a training program for our members. So friends, I think this is an important thing because these experts like, let's say, David Lamanto and other experts, Professor Farooq, to get them once a year in a conference itself was very difficult. And now we are able to approach them. We are able to request them to join us in a webinar and share their experience with us, which helps exchange of knowledge. Before I end, I would like to announce, and I take Dr. David Lamanto's permission, that this year the ELSA is happening in September. It's a virtual meeting, and you can see the banner behind him in the background, 11 to 12 September. And our postponed meeting, which was supposed to be in the 3rd week of July, Indo-UK Surgicon, which was to be held in Edinburgh, is also being held virtually this year in October, 15, 16 October. So I think this is the way to go. Virtual rules at the moment. And it also makes lives easy. You know, we are sitting at home, we had a nice lunch, and we are sitting here, and 1 hour later. Otherwise, for a conference, you have to travel long distances away from your family. You are staying in strange hotels, and obviously you enjoy company of your friends, but here also we have it. And so I welcome you all, and I hand over to the moderators to start the academic session, please.
Thank you, President Sir. Thank you, Indian Association of Gastrointestinal Endosurgeons, for giving Dr. Kanagvel and myself, I am Dr. Sumit Shah, this opportunity to conduct this international collaborative webinar on the myths and aura around the smoke in surgery. To be truthful, when I was first asked to conduct this webinar, my first response to our academic council coordinator, Dr. Deep Goyal, was, is there enough material that we need to conduct a full webinar on surgical smoke? And he said, you will be surprised. And I truly was, because as we started reading this, and as I and Dr. Kanagvel collaborated to look at the myth and aura around the smoke in surgery, we found that there is a lot to be discussed. There is some things that we know, and there is still a lot to be known. So going ahead, in this presentation, all the faculty has already been introduced. So friends, nothing in this world is to be feared. It only needs to be understood. So recently, because of this COVID-19, the smoke has come to be, the surgical smoke has come to be feared, and mostly because the surgical smoke is so incompletely understood and has been so incompletely studied by the surgeons who face it every day. And this is one of the quotes that is given to us by one of our faculty, Dr. Parveen Bhatia. And he said, absence of evidence is not evidence of absence. and caution is warranted. So therefore, many people continue to be not bothered about it, because they say that there is no evidence of COVID-19 in the smoke. But again, its absence is not evidence of absence, so caution is warranted. So next slide, please. So we go on to, to know whether what are the potential health risks of surgical smoke. Now, we know that, the smoke can, whether it is the smoke from the traffic, whether it is surgical smoke, any kind of smoke will have certain potential risks that cannot be beneficial for our health. Now, it is said that if you do a whole day of surgery, it could be equivalent to smoking almost 25 to 30 cigarettes per day. A day-long surgery is as harmful as 27 to 30 cigarettes per day. So now, starting with this, I would like to ask our eminent faculty, Dr. David Lomanto, to first tell us that, what are the components of the surgical smoke, and, why does he think that, the surgical smoke could be a potential health risk? So, Dr. Lomanto, over to you to tell us about, components of surgical smoke and why they could be a health risk.
Thank you very much for the introduction and to involve me in this webinar. And we are always happy to collaborate. And then we are talking with Raman to support probably a IAGES conference in October together. So what about the smoke? I think we need smoke in terms of puff, but also in terms of surgical smoke. Why? Because it's quite difficult to do procedure without ditermin, without advanced energy. But we need to use in a proper way. And I must say I was a kind of campaigning for use of smoke protection in OT since long time. During the normal laparoscopic surgery, we should start to use it for, not because of the COVID, because the smoke that is produced during electrosurgery produce a lot of toxic compound that goes from the simple carbon monoxide that is also in the cigarette, in the cigar, to acrylonitrile, hydrogen cyanide, benzene. Product of combustion produce a lot of chemical, but it's also harmful to the OR staff, nurse, doctor, causing a respiratory problem because we can inhale, even though we use a mask, this toxin, because the smoke produces a bioaerosol of both with inside dead cell, live cell, bacteria, and also virus that are quite not so thermosensible. So the surgical smoke and the particle that produce, for example, 1 gram of burnt tissue. I just imagine when we do a wide dissection, mastectomy, or open the abdomen, 1 gram of tissue is nothing, but you imagine it's equivalent to smoking 6 unfiltered cigarettes in 15 minutes. So that's why we should use a kind of a device to avoid that we got intoxicated. And should be. That's why now I think it's a good time with the happen of the virus that we start to talk about surgical smoke and risk in OR for all staff.
Yeah,
that's
thank
all.
you. Thank you. Yeah, that's I think a very, very lucid answer, because there are potential chemical carcinogens which could include benzene, styrene, many others. There could be potential biological, particles inside the smoke, bacterial, viral, all kinds, and therefore these can pose potential health risk to the not only the surgeon but to the entire OR staff. Dr. Kanagwel.
To briefly tell the flow, having got a nice introduction by Dr. Sumit and Professor Lomanto, now we would like to tell how our discussion is going to go. We are going to initially talk about the risk of the smoke, then insufflator safety measures, connection safety measures, and what are the role of filters, and a little bit about the scavenging systems. At the end, we will try to sum up with a guideline-based approach of this problem. So now I would like to ask Dr. Farooq. What are the common smoke protection measures one would normally apply to a OR in a day-to-day basis? Can you enlighten us, Dr. Farooq, in this regard?
Yeah, so normally we are relying on ventilation of the OR. And secondly, our personal protective equipment, especially the face mask which we use. So in the presence of a good ventilation, a good HVAC system working with the HEPA filter on, there is a dispersion of this smoke. So most of the common ORs would not be concentrating much on the evacuation system. And especially if you are having this respiratory protection, the face masks, that is a great protection. So normally this is what we use here, laparoscopic surgery, but specific smoke evacuation devices.
Thank you for giving a very fine introduction, Professor Farooq. Now we move on to the specifics. One should understand the fundamental difference between smoke and the plume. Say smoke, whatever comes out of a combustion, can be electrical, can be mechanical. But then plume is one which has a combination of both combustion and non-combustion processes. So one should be aware plume is more dangerous than smoke. So there's a subtle difference between these two. I hope the panel will help us to understand these issues as we go by. Sumit.
Yeah, so, we know that the components could be some water vapor, some chemicals, some particulate matter, some biological elements. But what is of really relevance to us in this COVID-19 era is the viruses. And because that is the reason why, there has been so much concern regarding the smoke. So my question once again to Dr. Farooq. Dr. Farooq, can surgical smoke transmit viruses? Let us just get this over with before we go ahead and say, how can we protect ourselves from the smoke? So that is the million-dollar question, that can surgical smoke transmit infection, especially the COVID-19 infection? What is your view on this? And then I can maybe take another couple of opinions on this. Can it transmit the COVID-19 infection?
Yeah, so if you talk about scientific evidence, we do not have exact scientific evidence that this COVID-19 virus can be transmitted in smoke. But seeing the previous evidence, we know the case reports of two surgeons acquiring this laryngeal papilloma because of HPV. We also know the reports of getting HIV, and we also know the reports of getting hepatitis viruses through these surgical smoke. So yes, there is a potential that this is a biohazard. This smoke is a biohazard, and it can cause infection, and it can transmit COVID-19 infection. So I agree with that.
So, Dr. David Lomento, I will just sort of, just pass this question quickly through all the faculty, because this is the million-dollar question. What is your opinion regarding transmission of COVID-19, viral transmission through the surgical smoke?
Okay, the research and study on COVID-19 virus, I think, is still ongoing. And we don't have much data, except that we know the size of the virus, that is 0.06, 0.114 micron. It can be found initially only, they think there was only in a nasal swab. But today we know that it's also present in the sputum, not only in the big parties, but also small. But it has been also isolated in other parts of the body, like peritoneal fluid, that is very important for us, a gastrointestinal tract, in the bile, in the stool. So I think it's not only the smoke that is dangerous, but the surgery itself, because contamination may happen not only through the smoke. So still, it is the danger of surgery in patient positive require all the precaution, PAPR, respiratory, and double protection of gowns. The gown, there must be a special proof, and so on. It's not only smoke and mask, but also we can get infection from fluid.
Thank you, Dr. David. Dr. Kanagwal, over to you.
And I'm happy to have Professor Mario Sainz Ramirez. I trust I pronounced the name correctly, Professor. To briefly introduce, Professor Mario serves as the president of the Latin American Association of Endoscopic Surgery, and he has close to a silver jubilee years of experience in the field of surgery. His area of interest includes gallbladder surgery, the entire gamut of minimally invasive advanced surgeries. He concentrates on digestive resections, of course, on bariatric and more on advanced laparoscopic surgery. On behalf of the IAGES and my co-faculty across the globe, I take immense pleasure in welcoming you, Professor Mario. So with that, we move on to the next important thing. Can I have
Dr.
the honor of... Yes,
Dr. Kanagwal, can I add something?
Please, sir.
Regarding the viral transmission and emission.
Please.
So
Please
emission of the virus, yes. So emission of the virus would happen when there are aerosolization procedures being done. So you know that those patients with suspected intubation, extubation, tracheostomy, suction, all these things are basically endoscopy and gastroscopies. All these procedures are likely to produce viral emissions. So these viral emissions basically, as we all know, that the transmission happens to the droplets. And these viruses are so small that they can be even transmitted to airborne, especially in closed confined spaces. So I think this transmission has to be stopped. And the best way is that all those areas in which viral emission is happening, we need to have a proper level 3 personal protective equipment, and that includes all the other things along with the face piece protection and other gadgets.
Thank you, Dr. Farooq. Thank you, Dr. Farooq. This brings me to just, what you have just said, types of devices and aerosolization and the particle size. So, Dr. Mario, welcome to you. And this is the question that I would like to ask you that, what are the different types of energy devices? And, are they different in the aerosolization? Because they produce different size particles, monopolar versus bipolar versus ultrasonic and, laser ablation. So just over to Dr. Mario to help us know that different energy devices and their impact on aerosolization. Dr. Mario, can you unmute yourself?
Good morning in Costa Rica. Thank you very much for the opportunity to participate. And since the start of the era, since the 1920, when the electrosurgery going up in the use in the surgical field, there have been many devices. The most common is the monopolar surgery, and it is the one that is known to produce more quantity of smoke. We also, in the last year, there are another devices that, like the bipolar, for example, the ligature, that is very common, and for the it is one that produces less quantity of smoke. Also, the ultrasonic scalpel produces bigger particles, but also in a large amount. Then now the best energy devices to use is bipolar cautery.
So that is the safest energy device at this moment to use. Right. So thank you, Dr. Mario. And our next question to Dr. Praveen Bhatia. Sir, Dr. Bhatia, sir, what are the important reduction, the smoke reducing strategies? So that is important because we once we use, whether we use electrocautery, whether we use the ultrasonic energy, there is some water vapor or some smoke that is going to be produced. So what are the important strategies to reduce the smoke production?
Thank you, Dr. Sumecha and Dr. Kangaval. Our basic philosophy is that I would love first to disagree that the virus has been found, COVID virus has been found in the smoke. It has not been found. A lot of studies have been there, but it is still not found. One. But basic thoughts are that how can you make sure that the less of smoke is produced? Either it can be at the source or it can be at the level of laparoscopy or open surgery. For preventing or reduction of the virus or smoke formation at the source, God has created the planes only for the surgeons. We should always respect the tissues. As you know that we always say, tissue is the main issue. We should not fulgurate each and every tissue which is coming on our way. One. So the judicious use of either bipolar or monopolar or harmonic should be used so that less smoke is created. One. Second thing is that when we are using these energy sources, our target should be that we work on a low voltage cautery, BOVI or monopolar or bipolar. We should definitely reduce the voltage so that ultimately the smoke production is less. And third point is that we should make sure, for example, if we are doing laparoscopic cholecystectomy, we should make sure that we attach one of the cannula with the tubing, and the continuous egress of the smoke is being done when we are using the energy source. If, for example, if a lot of smoke collects in, and most of us, the surgeons, especially the young surgeons who are assisting, we had the habit of opening the cannula and taking the gas out. So that should never ever be done. That should be stopped. So it should be a continuous slow egress of the smoke that will lead on to clear vision in the laparoscopic view, and that will ultimately help. So our thinking is tax at source, less production. Even if it is being produced, then it should be continuously going out, and that will ultimately reduce the smoke production.
Yeah, so there are certain local smoke evacuation systems which are available with both open cautery as well as the laparoscopic cauterization system, which help us to reduce the smoke in the surgical field. But I will request Dr. Kanagvel now to ask our esteemed faculty, Dr. Vinay Mahendal, regarding the various filters and what is their suitability.
Sure, Dr. Vinay Mahendal.
Yeah.
I think now everybody is concerned about the type of safety precautions after the onset of the COVID.
Yeah.
How we are going to control the smoke, one, at source, how we are going to handle the smoke after it is produced. Can you briefly tell us what are the fundamental availability of type of filters? Say, if you can address where filters can be used and what are the types of filters in brief. Then later we move on to our innovations at a little later time.
Yes,
now let us have a very clear
in conjunction with what Dr. Parveen Bhatia has said, don't think that it is too short a time since the COVID-19 set in. One doesn't know whether it is going to be infective or not infective. So we presume and take care that we take precautions to avoid this. Otherwise, also we don't want smoke. The very fact that the assistant immediately opens the cannula to let out the smoke is because one cannot see. But that apart, for COVID, we have to have certain things. And there are different types of filters, external filters. The filters which can be put on the ports or cannulae. They can be put at the insufflators, or there are different gas scavenging systems. Actually, the most important thing is which came initially when they were residents, there were new things to come. There were air conditioners, and they were talking about exchange of air. Now these filters, there are different types of filters like UGFI, ULPA, etc., which are really simple things. The simplest type of filter is under gravel filter, which is the simplest thing is available in your fish tanks. Or there can be ultra low particle filters, charcoal filters, and one is very conversant with HEPA. These are high efficiency particulate air filters. Unfortunately, practically what happens is in a set of operation theaters, only one or two theaters has got HEPA filters. And we, the laparoscopic surgeons, do not have access to these. Only for joint replacement, they are given these theaters. That apart, these are the filters which can take care of the particulate matter.
Dr. Vinay, sir, can you please tell us where all filters can be used? Which of the part of the surgery, assuming we have a cholecystectomy or we have appendicectomy, the filters, we can apply filters at various levels.
Yeah.
What are the important points where we can use filters?
To tell you the truth, I have not used any one of these filters, but for smoke evacuation, I would put a drainage tube or say Rice tube or something through one of the 5mm cannula. This tube can be blocked. When necessary, you can connect it to a bag and evacuate it through the tube so that there is no contamination in the air. But recently, the in April issue shows Italian and Israeli surgeons. We have worked on one very simple and nice system. This was also sanctioned by Technical Committee of European Association of Endosurgeons. They used electrostatic filter which is used in ventilators. You get my point. The small filter which is on the ventilators, they connect endotracheal tube connector which is connected to a tubing. This tubing is connected to our cannula. So I would use this simplest type of filter, not expensive. All of us can use it. You people in corporate hospital or anybody working in a nursing home, they can use this filter. This is the simplest filter we can think of. All other things, you have to take assistance of the architects and engineers to before the theater is made ready.
Okay. Thank you, Dr. Vijay. And I would quickly sum up the entire filter business. See, the filters are at the patient side or an external filter out of the OT, right? So the filters start from the port level, as there was telling the connection points. Then you can have filters at the insufflator level. See, these are the areas where pressures are higher. So there are filters at the port level. There are filters at the around insufflator levels. And of course, the entire gas. I would say the suctioning, the scavenging systems of the anesthetic equipment, and your laparoscopic exit tubings. They all can be integrated to one gas scavenging system. So all these points can have filters depending on the amount and the content of the smoke. More of vapors, then you need a set of filters. More of fluid, you need a set of filters. So I would say it should be a gradient-based filtering system. So you don't end up your filters clogged up and your gas does not get sucked out. As well, you don't want your gas to be taken into free flow in spite of presence of fluid. So it has to be a balanced approach. That should be the right thing.
One thing I forgot to add, many of these insufflators are having a filter at the outlet, if you see. There is a small filter to which the tube is connected, which goes to the cannula.
Right. Thank you, Dr. Mendel. Going on, moving forward, so far we have discussed on why this surgical smoke is dangerous, and using different filters, and we will go on to smoke evacuation systems. So there can be local smoke evacuation system and there can be devices, because we understand that despite taking all precautions, we have still yet not reached the stage of a smoke-free surgery. So now my question goes back to Dr. David Lomanto, that, sir, can you please tell us that, how understanding that smoke evacuation is never 100% proof, what are the other common safety measures we can take? And please say a word of both, some smoke evacuation for open surgery as well as for in minimally invasive surgery. Dr. David Lomanto, please.
Okay, what we need to understand that we know about the virus. We are talking about the smoke and virus because I think for non-virus situation in which there is a low risk, I think the simple smoke evacuator, either passive or active, are okay. So for in terms of COVID, I think we should use not only smoke evacuator, but also OR that they have a HEPA filter and a positive pressure. So we know that the virus size is between 0.1, below 0.1, let's say, micron. And the HEPA filter, actually, they are not 100% because they can remove smaller virus up to 0.3. What are more active are the ULPA filter, because the ultra low particulate air filter can remove up to 99.99.9. So because they can remove virus or bacteria that size less than 0.05 micron, not 0.3 like HEPA filter. So that is very more. So ULPA filter. In terms of ULPL filter, we do have some kind of filter, and we can say we have so-called passive filter and active filtration device. The passive filter, I think we have some in commerce by Micropore or other, and also they remove the plum away as surgical evacuator. This one can be attached to any, should be attached to all the trocar. But also we have active smoke evacuator. We have also some do-it-yourself smoke evacuator, in which the tube, I think there's our friends from Tarki Mahir Osman, they published one paper on making a bit like a chest tube drainage, put the tube in a bottle with fluid, but the fluid must be Sidex, cannot be saline or water, because must be active against the virus. So the use of smoke evacuator is very important, but also a proper use of it. It means we need to connect all the trocar except the insufflation. We need to avoid any leak around the trocar. So it means even the incision of the wound must be smaller, little bit smaller. In this way, the trocar is properly. Even the valve of the trocar shouldn't leak. We should avoid to remove the specimen only after. So we should use precaution, should remove the specimen only after the valve of the insufflation is closed, the evacuation, remove all the gas, and then we remove it. Even drainage are a culprit for bringing out smoke. So we should even avoid the use of drain. So it's not only the device, but also how we use the device, if we use it in a proper way. That's all.
Yeah, thank you.
Professor Lomanto, I'd like to hear from you. What is your viewpoint on commercial gadgets? Like most of the companies have come up with systems. Do you think they are any different from what has been being used so far in our ORs, and now we are changing a paradigm approach towards handling the smoke by using these devices?
Actually, there are few devices. The most common device that we personally use, but we have before the virus, we used before, is a Rapid Vac from Medtronic, and IS3 from RB, because they come in a package with our diatemy machine. So we already used before, because sometimes it's quite annoying when you do laparoscopic surgery and you have a lot of smoke because of use Thunderbit or high energy, high frequency, advanced energy. So we want to have a clear view. So that's why we use a smoke evacuator even before. So in this way, we don't need to open the valve and breathe. So automatically the system sucks the smoke that you produce with the energy. So when you do bariatric surgery, when you do hernia, when you do lap chole, you have a lot of smoke. So we use the normal smoke evacuator. And all this smoke evacuator, at least the RBIS3 is equipped with the ULPA filter, same the rapid vac from Valley Lab. So you can see in the slides, you can remove up to below 0.01. So it's quite effective. But as I say, we should also avoid any spillage of smoke through other areas. So use a device, commercial device, that are equipped with the ULPA filter and are able to filter particles that are less than 0.1 micron.
Point is taken, sir. Dr. Smith, please.
Yeah, so this, Dr. Kanagwal, if we can go back one slide, because I think that was for, comparing the various smoke evacuation devices. Yeah, this one slide. So like Dr. Lamanto has already said that, there are many smoke evacuation devices available today in the market. And we compared, this slide is taken from the paper which has been cited above. And this is a very nice table because it compares, from various companies. There is no conflict of interest, but we can tell you whether it's ConMed, Cooper Surgical, Liticon, Medtronic, Olympus, Stryker, or there can be some other companies like Dr. David said. Most of them are using, ULPA filters, ultra low particulate filters. They have smoke evacuators for both 0.01 to 0.1 micron. So almost all of them have active evacuation systems, so that the moment you start the electrosurgery, the device is going to get switched on and there is going to be a rapid evacuation of the smoke. Now, why is this important to have a smoke evacuation devices? Because, the evacuation is at least 8 to 10 times faster than a passive evacuation. So most of the times when people are saying that we will connect the tubing to a 5mm port and put it through the hypochlorite solution, you are using a passive evacuation system, and which is much slower compared to this active smoke evacuation devices, which is apart from the fact that they have been studied in great detail and they've got the ultra low particulate filter also attached to them. Next slide, please. Dr. Kanagwal.
Now I'd like to invite the attention of Dr. Farooq. Dr. Farooq, sir, what is your take on, is there a standard which is existing for OR air quality, which has been already there? And is there a standard, like a bare minimum degree of contamination which are allowed? How do we grade the contamination of the OR air? Dr. Farooq, please.
Yeah, so first of all, I'll go to the air ventilation system. I think there are two types of ventilation which is present in our air. That is the positive airway positive pressure ventilation, and the other one is a negative pressure ventilation. Well, ideally, for a COVID positive patient, we should be using a negative pressure ventilation. But even the positive pressure ventilation with at least a positive pressure of 2.5 mercury is the required one. So now there are two systems. One is the turbulent air system, and another one is the laminar flow. Now, for the turbulent air system, the recommendation is that the turbulent airflow, there should be a air change of at least 6 times per hour. And the good one is more than that. So 12 is air changes per hour is the recommended one. So one is the air change. Laminar flow, if that flow, you need at least 200 air changes per hour, which is very costly, and I think which has a lot of burden on the hospital as well. So regarding the air quality, so it depends on what type of surgery you are doing. So if you are surgery in which there is a high risk surgery for infection, like you are operating on a transplant patient, or you're operating on a hip replacement or a knee replacement, where you cannot take the risk of infection. So the air quality, the biological burden should be like this is called class 1. It should be less than 10 colony forming units. But mind you, it is biological burden. It does not say anything about the particulate matter or any gases around it. So for ICUs, less than 50 colony forming units are acceptable, and for general ward, less than 200. So this is what we are doing it, but I am not aware of this happening, especially in the wards or in the. So I think we need to know the routine, especially in those areas in which you are having operating on COVID positive patients. We need to know the air quality of such theaters.
Point is well taken, sir. Dr. Sumit, please.
Yeah, so once we know that, we have adequate protection, we have the smoke evacuation devices, we have tried to reduce the smoke, then we come out over to the surgeon protection. And my question now is to Dr. Mario. Dr. Mario, can you tell us something about the various surgical masks and the protection that they offer? Because till now we have been wearing only the regular 3-ply surgical mask. So we would like to know more what kind of surgical mask, what is the role, and what is the limitation in a surgical mask?
Professor Mario, can you please unmute yourself, sir? We are
Dr. Mario, can you please unmute yourself, sir?
Thank you. Yes. The surgical masks, they are the most commonly used masks. They have the benefit that they are fluid resistant. Splash body fluids, but they are not protect to all the particles contained in the smoke. Then now it is necessary to use the N95 because surgical masks don't protect against aerosols, and the surgical masks are not the sufficient protection when we are in contact with COVID patients. Then in this case, at least when we are doing a surgery in this time, or better forever, we must use the N95 mask. They are technical, they are respirators, and they have the ability to filter around 95% of the particles on the environment.
Thank you.
The masks that you can see now in the screen, some of them are very hard to obtain, and now also the N95 mask is and sometimes it's very hard to get them, but the general recommendation is that we must use the N95 mask for surgery.
Thank you, Dr. Mario. Moving on, that now I will come to the issue of respirators. Because now we are seeing every day, you are seeing new fancy photographs of surgeons wearing different types of respirators. And this question goes to Dr. Praveen. Am I audible?
Very well, sir. Please go ahead. You are okay.
Yeah, it's great. So now, following surgical masks, I would now go on to the issue of respirators, because now we are seeing surgeons posting photographs every day in different kind of, gears. So Dr. Praveen Bhatia, sir, can you tell us, what is the role of these respirators, and are they really required, or is just an N95 mask enough?
I would say mask is not a big ask. Mask is not a big ask. In order to prevent the transmission of the aerosols from the patient to the surgeon, or from the surgeon to other members of healthcare, mask is a must. But as Dr. Ramirez was also mentioning, that mask has to be used in such a way that there are no loopholes. What I mean to say, that if the aerosols can travel from this side to this side, or somebody is wearing the mask on the neck rather than on the nose and mouth, then obviously it is not serving its purpose. One. Second is that many times all of us have seen that if the mask is worn for a long time, then definitely the discomfort can occur in long-standing surgeries, and that can lead to challenges in the surgeons also. So thinking is that, yes, as you have rightly put, that there are so many things which have come out. Only thinking is that we should give our best. There is safety in more safety. So if we do not allow the aerosols to come in through the sides of the mask, that is good enough. But now the respirators have come, and these respirators, as you can see, the different kind of respirators are there. Some are having like as if you are landing on Mars. These kind of respirators are there, and they are powered also, they are non-powered also, they are having. So basic thoughts are that we should allow no aerosol to go into us and ultimately cause a challenge. And all of us know healthcare workers are the frontline workers, and we can be exposed to the viral load, and that can lead and to cause cascade of events. So these are not exactly fancy looking, but they are just taking more precautions. And only, as you mentioned, the only challenge is that definitely they are costly. And second thing is that, yes, one has to vary according to the fitting level also, whether they are tight fitting or whether they are loose fitting. So one has to be careful about that, and one should know the limitations of these respirators also.
Thank you, Dr. Bhatia. Now, one question, because many of our surgeon colleagues across the globe are working in certain resource challenged conditions. That is, we always talk about high flown things like having negative pressure operation theaters, laminar airflow, air exchanges more than 20 per minute, and different devices. But we know that there are resource challenge conditions, and surgeons are operating in different conditions. So quickly, I would like my esteemed faculty to say a few words of wisdom for those who are operating in resource challenge conditions. Starting with you, Dr. Bhatia, and then I would go on to Dr. Vinay.
First of all, I must request Dr. Kangaval to just show me, if you allow me to show the small video clipping which I had sent it to him. Basic thoughts are that we are, be honest, we are not resource challenged, but definitely we are innovative. And our thoughts are, if one is able to get those kinds of filters, nothing like it, if you are having it, or if, for example, you are doing laparoscopic surgery, if you are doing laparoscopic cholecystectomy, then what we take is that we put in the Veris needle at the Palmer's point, right at the beginning, and then through the Palmer's point, we attach this tubing, which is a sterile tubing, suction tubing, and this is attached to this filter. And as this filter is having the heat, moisture, bacteria, and virus filter. So these are the filters which endotracheal intubation, when the surgeon anesthetists are using. So they are using these HMEF filters quite a lot, both on the endotracheal tube side as well as on the Boyle's apparatus. So this is connected to the suction tubing, and then this suction tubing is ultimately dipped into the sodium hypochlorite solution. And in this one, we just put in a small tubing so that the gas leak is not there. And this sodium hypochlorite solution is 10%, but we dilute it to 5% so that ultimately the bubbles are not coming out. Our thinking is, as I mentioned previously also, we can go back to the slides, we can we should have the continuous egress of the gas. If it is not a continuous egress, then the chances are that we will not be able to get the best possible view. Second thing is that we mentioned that when we are putting in the instruments and when we are taking out the instruments, then also we should be very, very careful that we are not putting the instruments in an oblique fashion into the cannula. All the new trocars have to be used, should be used so that the gaskets do not cause any leak of the air. Third is that we believe on using the OptiView so that we are not having a loose Hassan type trocar cannula in which the gas leaks through the sides of the cannula. So one should be very, very careful that, as Dr. David Lamento had also mentioned, it should be a smaller incision rather than a bigger incision, as we had been trained to do in previous surgeries. And when we are taking the specimen also out, please make sure that all the trocars have been taken out under vision. And then we should not believe on the suture port closure devices at the moment, but we should close the ports from outside once the gas has been taken off, so that the viral spread is not there for even our assistants or our healthcare workers. These are the small points which we feel that one has to be very, very careful. There is safety and more safety.
Dr. Vinay, would you like to
Yeah.
add something to this?
Yeah, I thank you for including this topic, because majority of surgeons and more importantly, majority of patients in the world are from resource challenged conditions. So it is very important to think about this. Before I go ahead, I will just important thing I was told was that this coronavirus is a little larger than hepatitis B and hepatitis C virus. So whatever precautions we have been taking before probably will come in use for this condition. Now, one thing I would like to add to what Dr. Parveen said about the evacuation system and what Sumit was saying, that this is a passive system. One can adapt it by using intercostal drainage bottle. You understand, the underwater bottle which is connected to intercostal drainage. It has got two outlets, and both the outlets are above one outlet is above the level. So whenever required, a suction tube can be attached to the outlet of that bottle, and your system will be more effective. Number two, about the mask, there should be minimum personnel in the theater. The mask should be proper. If ideally there should be a face shield, and if you don't have a very massive PPE, even what kit we are using for HIV cases, for seropositive cases, if everybody uses that, at the end of the surgery, this can be discarded, and at end of every case, the theater can be sanitized and fumigated. So this way we can minimize the risk. You can never minimize the smoke coming out during exchange of instruments or while doing surgery. The whatever suction things we have, the simplest evacuator we have got is the suction machine in our theater. This suction cannula. In open surgery, along with the suction pencils, it can be easily used. We usually don't have dearth of assistants. They can always follow the thing, and that can be used. So even if you don't have a suction, the cautery pencil with suction, which costs about 5 times the normal pencil, you can use your regular suction. So these are, I think, if you stick to the basic things, you can do the surgery safely, even with our challenged conditions.
Thank you, Dr. Vinay. So, yeah, open versus MIs. I will leave Dr. Kanagwel to address the question to Dr. David.
Professor David, you've been a proponent. You have seen the best of the open surgeries, best of laparoscopic surgeries, and of course the best of robotic surgeries. first I would like you to address the common question. The initial, I won't say guideline, initial directives said no open, no laparoscopic surgery. All surgeries have to be done on open. Then later evidences, later publications may or may not be evidence based, but then scientific based publications came up. They said only laparoscopy. I want you to address the issue in two different heads. Which is better, open versus minimally invasive? The next question is robotic better than laparoscopic? These are the two issues which I would request you to address.
Okay, thank you. Thank you for the question. It's quite interesting question. Why? Because it goes along with the knowledge that we had for the virus. Of course, when the situation come in January, February, all over the world there was alarm because of the risk of aerosolization of the gas and CO2. So the first one was the Royal College of Edinburgh. They come up with the guideline, no laparoscopic surgery. And of course, after that, we know much more, and there were a bit of concern. What is better? I believe that between the two, open and laparoscopic surgery, I think if you need to do a procedure that is fast, reliable, patient go home earlier, I think laparoscopic has their own advantage, especially because with laparoscopic, we can control the surgical smoke much better than open surgery. But of course, at the end of the day, it depends on which situation you are. And also depending which situation you are, it means if you are in a situation in which the country is in a state of pandemic, you don't do anything. You just do emergency. If you are in a situation in Singapore, we have so-called red, orange, below the pandemic, in which the situation is under control, but you still need to have a bed capacity, ICU, ID bed. So you do some surgery that is only oncological surgery, trauma, emergency surgery. And for that, I think the role of laparoscopic can be quite minimal. So if you are in this situation, so of course, at the beginning, we also stop, but then after that, we restart, especially for acute cole, acute appendectomy that cannot be postponed. We will do laparoscopic with the proper precaution. Robotic surgery itself follow the guideline of laparoscopic because it's nothing else different, except that maybe for the operator at the console is far away from the operating room, is outside, so it's safer. But in terms of exposition to the gas, to the surgical plume, everything, follow the other rules of laparoscopic surgery. Even the two statements from the European Society of Gynecology, the American Society of Robotic Surgery, they always in the guidelines say the same. The benefit is only for the patient that go home earlier, but the risk overall for the patient are similar to laparoscopic.
Thank you, sir.
I hope I
think you covered the entire spectrum.
Answer what you expect.
Correct. One more thing, there have been some publications which are coming up. Of course, they are not very strongly evidence-based, but they go on to say the robotic surgery, the movement of ports, especially with the gadgets, are pretty much limited. And laparoscopy seem to be marginally higher when compared to do laparoscopy versus robotic. But of course, it is the sealing of the device between the port between the tissue and sealing of the instrument between the port which is matter. Either it can be a robotic one or a laparoscopic one. Thank you, Professor Lomanto.
No, I want to add more things.
Yes, sir.
If you look at the, I think this gives you an answer. One of the guidelines of COVID and surgery is to keep the surgery short. So you want to reduce the exposure to the patient. And we all know that robotic surgery is the longest in the world. It takes AGES to do one case because of docking and undocking. So I think already this, I do robotic surgery. Yeah, I think also Deep does it. So, but we know that it's much longer. So if we consider this, I think laparoscopic is superior. Praveen is smiling, Praveen is smiling.
Point is well
I am
taken.
saying, just a sec. I am saying, I am surprised that how David Lamento is saying that robotic surgery takes ages. It does not take ages. It is a mindset which is important. One. And second thing is that as you carry on doing the surgeries, it has been proven beyond doubt that the number of hours, number of minutes also start decreasing. We do a lot of bariatric robotic surgery and the time definitely goes down. But we are not talking in this context.
It's still longer. It's still longer than normal. Now we are talking about situation of infection, active infection. So we don't do bariatric surgery since February. We stopped bariatric surgery since February because it's not essential.
Thank you, sir.
Thank you.
Sumit, take over.
Yeah, thank you, gentlemen. Now talking about, that, we talked about open versus laparoscopic, and initially the fears were there with minimally invasive surgery. But now that the fear is coming down and many places in the world, laparoscopy, elective surgery is starting again, I want to know from Dr. Farooq that, the key issue is pneumoperitoneum. Some of the things have been elucidated earlier, but would you like to tell us something more about, the pressure of the pneumoperitoneum, how to maintain integrity, and is there anything special that can be done while doing laparoscopic surgery in the patient? Dr. Farooq, please.
I think Farooq went out. He is asking to come in again.
Farooq is with us, sir. Dr. Farooq? Okay. Can I ask, I think we can share all the faculty this question. Maybe Dr. Parveen Bhatia, can you address first to the safety of the connections, then we will break into 3 or 4 to all the faculty. Can you briefly tell us what is the safest connection which is possible, and where all one has to be careful in ensuring the safety of the connection? We'll break this question into 3 so that all faculty get a share of this question. This looks more important for the practicing surgeons as such.
Sure, Dr. Kangaval, I would say that every point is important. Every connection is important. From the insufflator, as the filter is there, as we mentioned that if the filter is close to the insufflator, so one has to make it tightened so that there is no gas leakage there also, one. And as the gas tubing is coming to us, onto the patient, to the first maybe Virus needle and to the cannula, it has to be tightened in such a manner that the gas leakage is not at all there. Then the port entries also, the ports, as Dr. David Lamento also mentioned, the incision for example, 10 mm port should be 10 mm rather than 11 mm. Initially, all of us have been slightly liberal, but now the gas should not leak just outside the cannula. That those connections are very, very important. Another point is that when we are working in this era, in COVID era, our pressure should not be 15 or 16, but we should work on maybe pressure of 10 to 12. That I think one can speak to the next speaker, next panelist.
Sir, Dr. Praveen sir, I would like to hear from you. Having very, very dogmatically telling every connection is important. Point is well taken. Can you briefly address this, sir? Because all of us have seen connections, which is just push and leave it, push and twist, lower locks. So according to you, what at present should be the safest possible connection which we can adapt to? Because it is never no more like previously we used to have the Venflon cannulas to attach the gas and other things. I don't think which is right now justified to do that. Those are that. What is the best possible connection which is safe at this point of time, Dr. Praveen Bhatia?
Lever lock. I would say that all the connections all should have the lever lock, and definitely we should make sure that it is not loose at all and there is no gas leakage. There are some, I would say, the innovative thought that one can put in a gauze piece soaked onto the connection so that we can find out that if there are any bubbles coming out, again we tighten it. So this is a small thought, but again, lever lock is the best connection.
Absolutely. Now
the lever lock which works.
Yes.
Yes, sir. Now I move to Dr. Vinay Mandale, sir.
Yeah.
Sir, what do you think? In fact, there was a brief address by Parveen, but with your experience, what do you think will be the most optimal pressure to avoid smoke contamination? Because you addressed to something which is fundamental evacuation device. Then we moved on to the most sophisticated commercial device. Whatever device you do, but the fundamental pressure you set inside for the pneumoperitoneum matters for any device to work successfully. So what do you think will be the safe pressure, and what are the pressure parameters one should be keeping in mind to avoid a gross contamination, Dr. Vijay? Vinay, please.
When you were talking about maintaining the pressure, more importantly, I would be concerned about that my machine is good and it doesn't allow the pressure to go up without me knowing, which is dangerous to the health of the patient. You get my point? Which is more dangerous than this smoke. If the pressure goes too much, then it reflects on the patient's pneumatic condition. So the pressure I usually keep in an adult is about 13 millimeters of mercury. The flow rate is kept at 10 liters or so, depending the routine laparoscopic cholecystectomy or something. I am not doing bariatric surgery. So, unless the patient has got some abscess or something like that, I don't need extra suction to be added. So in that case, I can raise the flow. My machine, I have kept it in such a way that I can maximum flow I have is 25 liters. I don't need 40 liters and 100 liters of flow. I don't need it for my conditions. So for that, when you are, as I told you, when you are releasing the pressure, henceforth I was not concerned. But from this point that smoke evacuation is important and you must have evacuation gadgets, I would take this precaution which I told you before, that put in a tubing, connect it to a bag which you may or may not connect it to another suction machine, and put a clamp on it. Whenever necessary, you can release that clamp. So the evacuation is through that. Do I get my point?
Definitely, sir. Thank you, Dr. Vinay. Before handing over to Dr. Sumit for the next important thing,
Can
I request
add
Dr.
something? Can I go?
Yes, sir. Please, sir. Go
Yeah,
ahead.
hello. Can I add something here? I'm
Absolutely,
sorry, I
sir.
lost my internet connection.
No,
so
you
I
are
had
back.
to-
Very happy.
Alright,
We're
so-
happy to have you. Please share your points.
Yeah, so what I'm using is basically doing a deep neuromuscular blockade, because I most of the time operate on bariatric patients. So deep neuromuscular blockade gives you advantage of using a low pressure pneumoperitoneum. So we usually set it about 8 to 9 sometimes in a very obese patient. So that gives you not only you're using low pneumoperitoneum, but obviously there are less chances of escape and leakage of the because of the high pressure.
Point is taken, sir. Now I'm going to ask Dr. David Lamanto. Sir, what are the important safety measures of maintaining the integrity of pneumoperitoneum? And what are the safety features one should adapt, especially when you do the instrument exchanges or when you are trying to do end of surgery desufflation? How do you maintain the integrity of pneumoperitoneum, sir? Over to you, sir.
Yeah, it's quite challenging question. First of all, I think Parveen already say we should use the lower CO2 pressure. Why? And what is the low pressure? They ask you. I think there is no number because of depend on the patient. The patient is, you have enough working space at 8, you should work at 8. If you need the minimal working space at 10, it's 10. So you should work with the low pressure into the abdomen. Avoid the escaping. Avoid to use a disposable trocar, because the integrity of the valve is superior to the reusable. And if you use a reusable, be sure that the valve is not broken, especially if you use a sharp instrument like hook and scissor. You may damage the valve and make escaping. Of course, if you have money, you can use an air seal, for example. Air seal is we use for robotic. It's a high flow insufflator with a valve with a special trocar that avoid any output of the gas, so maintain the pressure very high, and also work as a smoke evacuator. So the solution. The rest are standard one. Avoid to change instrument multiple times, and low pressure, and avoid to use instrument that the trocar that are utilized thousands of times, that because they may leak more.
Thank you, sir.
Thank you.
Dr. Sumit, take over.
Thank you, Dr. David. And now, but whatever we do that, sometimes we have to use different kind of ports, like a hand port, or, even in the regular surgery, even in gallbladder, we have to do a specimen extraction. So there is leakage of gas at that time. And I would like to address this question to Dr. Mario, that, that how to avoid gas exposure, at the time of the specimen extraction, and what are the strategies to avoid, smoke at the time of specimen extraction. Dr. Maria?
Thank you. I think that the first is to maintain all the safety measures that you have mentioned before, safety of connection, the pressure of pneumoperitoneum, and when we arrive at the end of the surgery, then and after that, try to remove all the pneumoperitoneum with all the smoke before trying to the removal of the specimen. It is known that these hand port extraction devices usually they increase the risk of the contamination of the smoke to the personnel. Then it is very important to keep in mind to try to remove all the pneumoperitoneum before doing a bigger incision, to try to do the incision as smaller as possible, and to remove this, and after that, as soon as possible, to close the incision that we have done before.
Oh, thank you, Dr. Mario, for that. And so reducing the exposure to smoke at the time of specimen extraction, as Dr. Mario was saying, that we need to make sure that we have evacuated all the carbon dioxide into the safe evacuation systems, like we discussed before we give a specimen extraction. Use of hand ports should not be there, because there is more chances of gas leakage at that time. And the incision used to remove the specimen should be as small as possible and should be made after the pneumoperitoneum has to be evacuated. So my next times that we can never have enough of safety. So can you tell us if there is some safe level of exposure, or some safety timeline? How can we make sure that we remain safe of this exposure? Supposing if in a small for a small minute or less than a minute, if there is gas exposure, do you think anybody should get like very scared that they have got exposed to the gas? Or what is the safety timeline?
I would say that there is safety and more safety, one. And still, the excellence has no limits, safety has no limits. Even if the gas leakage is there, and as we discussed in the beginning also, the viral load is not there in the egress of the gas. It is not 100% that if the gas leaks, and then obviously if it has gone into your system, you will be having the COVID test positive afterwards. No. But again, the precautions have to be taken. Most of the times, as we mentioned, that we should teach our team members also. I think this is very, very important, that all the team members should be very well versant with what kind of work has to be done. Not only the surgeon, but all the team members have to be well versed. Second thing is that yes, whether you are taking the patient who is COVID positive or who is not COVID positive, if the test is done within 48 hours and then we do the operation and then we are absolutely sure that we are not dealing with COVID positive patient, it is definitely adding on to the safety. But now we should always feel any and every patient is a silent spreader. And if any patient we are dealing, we should take universal precautions for each and every one. Then only will be able to reach the target of absolute safety. So thinking is, take all the precautions, teach all the team members, and least egress of the gas should be there. And we should always use the protection, personal protection equipment thoroughly. We should not compromise on that aspect. And I must give you a small catch that one should definitely use the visor, one should definitely use the face shield, so that no spill of the gas or any biological content comes onto the face of any of the team members.
Thank you. Thank you so much. You know, we are coming towards the final few slides of this webinar, and but you know, I just wanted to know that, you know, is there a possibility that at some point of time we can have a smoke-free operation theater? You know, maybe every faculty can just put in a word, you know, on what they think is possible, starting with Dr. Farooq.
Yeah, so maybe we need to change our energy devices, maybe more of a electroporation sort of things in which there are less chances of producing smoke. I think more for the time being, surgery about it, for the time being is inevitable. The only thing is we need to see this and we need to take measures to basically reduce energy stream.
Yeah, Dr. David?
I think we should, Sumit, we should try to be smokeless. No smoke free is quite impossible, but at least reduce by use of all the precaution that all the speakers already have listed: small incision, use low pressure, use smoke evacuator, either passive, do it yourself, but do it yourself that works. Active, of course, are the best, and reduce the use of energy, low voltage if you use especially monopolar. So try to reduce energy that they create a lot of vaporization, like especially the ultrasonic devices. So there is a possibility to create less damage and less smoke. So I think we should implement all this in our daily OR. And it's quite simple to do because most of, even the active smoke evacuator by the company are not expensive. They don't require much maintenance. It's free per use. So that's what we should do.
Thank you, David. The idea then, what all our faculty is saying is basically to create a safe environment for the care of the patients who are undergoing whether open or minimally invasive surgery. And
for
also
for the care of the doctor, not the patient, the OR staff.
Yeah, the OR staff, the multidisciplinary team, you know, whichever is there in the operation theater staff, we should create a safe environment for all the OR staff. And I'll hand over to Dr. Kanagvel now.
Dr. Sumit. Dr. Sumit.
Yeah, Dr. Vinay, yes.
Yeah, I would like to add, you have put this, can we become smoke free? Anytime we have to use an energy device, it will never be smoke free. So laparoscopy is unlikely to do so. But to become less smoke, either we have to generate less or evacuate faster. To generate less, I think the idea is in open surgery, we can cut and cauterize only the points or use bipolar cautery, which is much better. The cutting current causes more smoke than the coagulation current, and bipolar the least. So I think these are the ways in which even during laparoscopic surgery, if one can use this judiciously, then the smoke can be less. And we have already talked about evacuators. I thought this point should be brought out, which is the preferred energy.
Dr. Praveen, sir, please.
One liner, where there is a fire, there is a smoke.
All
Thank
say.
you. Now I have a share of questions to all the faculty, including Dr. Sumit, because we have had few questions from the floor. I will take these questions now and then go for one quick completion remark from our side. Can I ask this question to Dr. Vinay Mandale? Sir, is there a difference in lethality of smoke? Say you were talking about monopolar is the higher, bipolar is the best possible thing, harmonic, laser. Do you think is there the damage caused by the smoke produce these different gadgets, monopolar, bipolar? Are they different in the risk, or are they different in the lethality of the smoke they produce, or it is only the amount of smoke which they produce or more? What is your take on this?
I would know only about the monopolar and bipolar cautery. I don't know exactly what happens in harmonic, but I think the quality of smoke would be the same, because both the things are burning the tissue, and whatever is caused by burning the tissue, whatever gases are caused, they will not be different.
Thank you, sir.
The denaturation of proteins, etc., would be the same.
The point is well taken, sir. But to wrap up, I would like to add few other points as well. See, please understand the fundamental principles of smoke generation according to the generators are something different. See, it is the cell which suffers the damage, and the damage is more extensive, it smokes off. See, one should understand very clearly whatever smoke produces 95% water vapor only. The 5% stuff is the most lethal stuff. And the width of the particulate matter which is generated by the device and amount of chemicals which are hazardous chemicals which are produced matter, of which at this point of time, the least particulate matter produced are by the bipolar, the biggest are by the ultrasonic devices. All other devices come in between. But for your information, there is something which is on the pipeline, the cold hemostasis devices like plasma devices and other things which are not yet commercially available. I'm sure we are not far away to get rid of all these gadgets once the cold hemostasis comes in. Because cold hemostasis, it is more precise and the principle of hemostasis is little different. So the heat generator is more focal and the particulate matter and the smoke generator are less. So I'm sure it definitely varies between the instruments, of which bipolar appears to be more safer. Dr. Praveen, please.
Yeah, I would just substantiate the same thoughts which you have given. That monopolar, the particulate size is 0.07 microns.
Exactly.
And for the ultrasonic, it is 6.5 microns, 0.35 to 6.5. And it is because of the vaporization, because of the water vapor, definitely the desiccation is more in harmonic as compared to this. And smoke particle size also matters when we are using the filters.
Thank
you. All depends on the temperature.
Dr. David, please.
This all depend on the temperature, because bipolar and harmonic, they use 180, 190 degree, while with the dithermy, we have the same effect at 100 degree.
I understand, sir. Thank you. I think I'm going to ask Dr. Sumit this question. Dr. Sumit, there is a question from the floor. How can surgical smoke exposure be prevented with the help of high filtration mask and smoke evacuation systems? Does it mean that I think the participant wants to know who is at more risk and who needs the maximum protection also? Can you address to this, Dr. Sumit, please? I think Dr. Sumit is shortly out of connection. Can I request Dr. Praveen Bhatia sir to address to this question?
No, I think we have just discussed that ultimately every small step is important. And we have to take all the precautions. I would never ever classify that who is at maximum exposure risk and who is not. So our thinking is that we should ultimately eat an elephant, and eat an elephant can be done only when we break them into small bits. So all bits are important.
Thank you, sir.
Can I answer that?
Most welcome, sir. Please, Dr. Farooq,
right.
please.
Right. So if you see that the smoke is produced, the surgeon is the closest person where the smoke is being generated.
Absolutely.
So surgeon and his assistant are the highest risk, and that's why open surgery has the lowest risk, and laparoscopy has the highest risk, and robotic surgery even has the lowest risk because the surgeon is sitting far off from the smoke generating area. So surgeon, other than the anesthetists and the rest of people, are high risk population.
So the point is, someone who stands next to the open surgery, if it is less than 40 to 60 centimeters from the operating point, or someone who is holding the port where instrument exchange is happening in laparoscopic surgery, someone who is close to the port where desufflation is happening, or someone who is at risk of disconnected connections getting exposed. These are the people who have higher risk. Now I move on to Professor Mario. Yeah, Dr. Mario, do we have any legal guidelines like surgical smoke has to be this much level, or do we have any standards which are set for the surgical fraternity? What are the safety limits of smoke?
Safety limits of smoke. I think that really as less as possible that we can have. I think that there is another thing that I think that usually increase the level of smoke is when we wash, and usually when we are doing surgery and it is bleeding, we tend to wash a lot, and if we keep the fluid inside the abdomen, then it increases the amount of smoke. Then it is important to remove all the fluid that we can, because otherwise it can produce a lot of smoke. But of course, the level of smoke that's we have to keep as low as possible during all the surgery, and to be very sure that at the end of the surgery we remove all before trying to remove the specimen.
Thank you, Dr. Mario. Dr. Vijay, you want to add something, please?
Yeah. If you want to count how much is the smoke, you will have to have a meter like radiologists have, that how much radiation has been there. I think it is difficult. The question was what is the safe level of smoke exposure?
Let me tell you, sir, I have something more. I actually wanted to wrap up at the guideline, but having a question being asked, I would like to share that information. To be honest, we have guidelines for particulate safety of the mask, for the respirator, for the insufflator, for the filters. Unfortunately, we don't have a standard limiting guideline for the surgical smoke.
Yeah,
if you look at it, it is sad to note 2017 standards are only still being followed. There was no revision after that. The OSHA, the Occupational Safety of the Health Hazards Association, it is part of the NIOSH of the CDC group. The only guideline or only standard which is existing is 1910, and we have 4 or 5 subsets of 0.1, 0.2, 0.3, 0.4. But very, very, very vague. See, if you are going to have ASTM standards for mask, if you are going to have micron standards for filter, it is definitely not a very fortunate situation. Then we have to, the scientific community and the surgical fraternity, were very serious to think about the minimum amount of smoke, legally permissible limit. I'm sure at this point of time, you do not have a legal number, but I'm sure very soon the societies will take this up as a guard and go ahead with that. Now I move on to the next question. Dr. David Lamanto, what is your take? There has been thoughts that the smoke generated is potentially mutagenic, carcinogenic. Is there any way or any published study which says a surgeon has contracted some infection or some malignancy because of the surgical smoke? Can you little bit elaborate on that, Dr. David?
I must say we have not direct evidence because is that we know in our surgical publication, we don't know in health hazard and work protection publication, but we know indirectly that smoke produce benzene, other carcinogenic substance, and we know the effect of the smoke. So we know that indirectly exposure to smoke may create hazard, may create a respiratory problem for user. Just imagine if you stay in OR and I always, when I pass by the OR where they do mastectomy, in which is a complete barbecue, I think you can feel the smoke everywhere. That's why our team now, I think since last 6 months, because all complaining, they start to use the open smoke evacuator. So there is indirect, but frankly speaking, I'm not so sure if there is any study on the effect on the surgeon or our staff. Anybody knows anything?
Dr. Vinay, please first, then I'll move to Dr.
I think every surgeon operates with mask on, so that may be reducing the problem.
The masks are not so effective. N95 is the best protection that we have, but it's not 100%.
No, I mean to say because like smokers, we don't get that problem.
Yeah, but still there is.
Thank you. Let us see what Dr. Praveen has to.
I would say that it has not that the surgeons have become carcinogenic, but human papilloma virus. All of us know the cases have been reported in which, for example, the surgeon or the gynecologist was operating on a papillomatous disease and ultimately caught the disease because of the surgical smoke. So these cases have been reported, but not the COVID, not the Australia antigen.
Point is taken, sir. So HPV infection to the laryngeal papillomas who do a lot of laser wart excisions have been reported. At this point, as Professor David and Professor Vinay said, do not have a straight evidence that something is carcinogenic or mutagenic. I'm going to ask Dr. Sumit. We lost Sumit in between for the connectivity issues. Sir, Dr. Sumit, like everybody has been talking about really different issues, but the most common issues, the inner side of the ports, the washers, the interface between the port and the instrument which is going in and coming out. Is there a safety standard for the washers? And what is the way we can check the integrity of the washers, Dr. Sumit? Dr. Sumit, are you with us? Please unmute yourself, sir.
Sorry. So, like everybody said that, it is very important that, especially in these times, we are trying to reduce the usage of reusable ports. So, because the usage of metallic reusable ports, which have been used multiple number of times, the chances of washers not functioning risk is much more. So, preferably you should use new disposable ports, and now very economical disposable ports are available. And not only that, if you are operating a COVID positive patient and you are doing laparoscopy, maybe you can use ports which have got filters inside them. So these are already ULPA filters, and not only do they have ULPA filters, they have Luer-Lock mechanism of fixation. So even if the gas, while your instrument is exchanging, that gas which is coming out can also get filtered. So that is very important when we are using these filter devices. These trocars. Dr. Kanagvel, if you have anything to add, you can say that.
I agree with you, sir. At this point of time, that OR theater managers, if they are going to reprocess the ports, they should have a leak test for the ports also. There are devices to do the leak test, or indigenously developed leak test can also be done. Leak tests are preferentially done from the patient side of the port, not from the head side of the port. So because the pressure is from inside out, so you can do integrity check. There are gadgets to do it. A very simple option. If one can afford, you can go for a new ports. Dr. Praveen, do you like to add something more to it?
Yeah, just as Dr. Sumit was also mentioning, one can add on the balloon ports. The balloon is inflated inside and the trocar is there, so that ultimately not going in, coming out, that can lead on to challenges in leak. So balloon.
Accidental slipping out, other things are chances.
So we have another method. We use this finger gloves and we put it on the metallic port, and then we use these washers. So they are very effective for escaping of the air leak.
Dr. Farooq, can you please describe what is the thing you're trying to tell?
So for the prevention of air leak in the metal port, what you can do is you can cut a finger of the gloves, so smaller gloves, and you can put it over that end, and then you can apply this washer over it, and then your instrument goes. So it is a very effective way of stopping the air leak.
Okay. That sounds quite interesting, and it's very easily applicable also.
Yeah.
So the last few questions now I have to the faculty. Now I'd like to ask Dr. Mario. Dr. Mario, you've been talking about, the faculty has been talking about the low application of current, lowest possible current, lowest energy requirement, lowest duration, all those things. Does it mean the low current is better than higher current? What is your take on this? There is a question from one of the participants.
Yes, it is described in some papers that as low energy as you use, that is as low smoke that you can produce, but also if you use less energy, then the damage of the tissue is also less. If you use a high energy, you can carbonize the tissue, then it's better to use as low the energy as you can. It's safer for the patient, safer for the production of smoke, and then safer for all the operation team.
Point is taken, sir. Thank you. The last question, I will request Dr. David Lomanto, sir, to take this question. So here, one of the candidates, we will have to know, they wanted to know, are larger particles more harmful than smaller particles?
Unmute. David, unmute yourself. Dr. David?
Yes, I'm here. So what is the question?
Sir, the participant wants to know, a larger smoke is more harmful or a smaller, the particle size, larger particles are more harmful or smaller particles are more harmful?
I think both are harmful because they create a reaction if inhaled in a different way. One be creating inflammation and another one creating contamination. So both are, there is not the size that matter, but it's the particle itself. So can be product of a virus, can be product of the tissue, so bigger size. So I think that it's not matter of size. They both are dangerous in a different way.
So maybe the candidate wants to know, because bigger particles can be easily filtered. I'm not sure whether that is the idea of asking this question, but your point is well taken, Dr. David. I think we are wrapping up. Dr. Vinay, what do you want to add?
Yeah. I only want to say that if there is smaller particle, you will need a filter which